Good evening, everyone. I would like to present information regarding caring for mental health needs in special populations in primary care. My name is Veronica Powell, and I'm in the course Neuroscience and Psychopharmacology with Dr. Frank Apati. Special populations include the elderly, the perinatal lactation, pediatric adolescent, LGBTQ, immigrant, migrant workers, and ethnic minority groups. Elderly and geriatric. Mental health needs among patients in the geriatric population are unique in the fact that this is a major time of transitions. Retirement from work, loss of close friends and loved ones, health issues physically as well as mentally, and loss of independence, just to name a few. Patients in this population, age 65 and older, struggle with mental health conditions related to transitions and adjustments to physical and emotional life circumstances. Mental health conditions include, but are not restricted to, the following conditions: anxiety, depression, dementia, delirium, and substance dependency. These mental health conditions are not always easily recognized. Indications can be subtle. Only about 10% of Americans aged 65 and older will seek treatment for struggles with depression. The total direct healthcare costs for treating depression in age 65 and older was estimated to be about $9.8 million in 2016. $930 million out-of-pocket expense and $7.4 billion paid for by public insurance programs. Diagnostics and DSM-5 criteria. There are numerous diagnostic screenings and assessment tools to aid in treatment approaches for this population. The PHQ-9 and the Geriatric Depression Scale can help guide the clinician in diagnosis and major depressive disorder. It is also important to assess for suicide risk. It is imperative that the clinician pay attention to the patient's presentation during major life events such as the loss of a spouse, inability to manage daily activities such as ADLs and IADLs. Significant memory loss is also an indicator of mental health decline. Treatment plan in this population. Pharmacological interventions include treatment with SSRIs such as sertraline or citalopram, SNRIs such as Wellbutrin and venlafaxine in some cases, and anxiolytics such as Buspar or hydroxyzine, and hypnotics to help with sleep issues such as trazodone and mirtazapine. Talk therapy to address depression symptoms as well as other issues that are related to this population. The PHQ-9 and geriatric scale can help guide the clinician to diagnose major depressive disorder and as well as assess for suicide risk. Labs include CBC with differential, electrolytes, drug screen, hepatic and renal function, and blood glucose testing. Referral options include a neurologist when the patient may show signs of dementia or other neurological conditions. Educate the patient, answer questions the patient or family may have regarding the care plan, provide adequate follow-up for the patient as needed. The population for perinatal and lactation. Patients in this population are usually within childbearing years, starting at late teens to adulthood. Women during the perinatal period are struggling with anxiety and depression, to include postpartum depression. This is a major change in the life of the prenatal and postpartum period up to the first year after birth of the child. For the partner and for the other children in the family unit, this is also a major change, and this may require intervention and resources as well. Postpartum depression is among the most underdiagnosed obstetric complications in the U.S. These conditions are estimated to cost $14 billion for 2017 birth cohort from conception to 5 years postpartum. The average cost per affected mother-child dyad was about $31,800. Mothers incurred 65% of the cost and children 35% of the cost. Diagnosis and DSM-5 criteria. Screening tools for the perinatal and postpartum mood and anxiety disorders include Edinburgh Postnatal Depression Screen or Patient Health Questionnaire, or the PHQ-9. Both screening tools can be used in the perinatal population for no fee and can be self-administered. The EPDS screen is also used to screen fathers as well. A score of 10 is the cutoff for a positive screen for mothers and 5 to 6 for fathers. Tests can be administered at first prenatal visit, during the second and third trimester, 6-week postpartum obstetrical visit, repeated screenings at 6 and 12 months in OB and primary care settings, and 3, 9, and 12-month pediatric visits. Treatment plan for this population. Pharmacological interventions. Only specific medications are safe for treatment of depression in the perinatal and postpartum period or lactation period. First line treatment is SSRIs to treat depression during this period, but it is important to use the lowest effective dose to reduce the risk for the baby. Psychotherapy is also indicated for treatment during this period for the mother and the father. Cognitive behavioral therapy and interpersonal therapy are among effective interventions. Providing education and resources to the perinatal, postpartum mother and father in crisis. Provide 988 suicide and crisis lifeline phone numbers in case of high-risk situations. Postpartum Support International provides helpful information for mothers and fathers, and the link is provided. Refer the patient and the family to resources as if needed for financial strains or supports for the family in the adjustment period. Population, pediatric and adolescent. Patients in this population are aged 3 to 17 years of age. Among these patients, clinicians will notice more than likely mental health issues in this group include depression, anxiety disorders, ADHD, and behavioral problems. The CDC reports that 9.8% of children aged 3 to 17 years old from 2016 to 2019 have ADHD, 9.4% have anxiety disorder, 8.9% have behavioral problems, and 4.4% have depression. Among adolescents, depression, substance abuse, and suicide are among the most concerning. 1 in every 4 American children was diagnosed with mental health issues in 2021. Average households spend about $4,361 per year. Diagnosis and DSM-5 criteria. Anxiety in this population is displayed when a child feels afraid when separated from parents, having extreme fear of specific things or situations, being afraid to go to school or being in other social situations, constantly worrying about something bad happening. Physical symptoms include heart pounding, difficulty breathing, feeling dizzy, shaky, or sweaty. Depression is displayed by feeling sad, hopeless, irritable, not wanting to do or enjoy doing fun things, changes in eating patterns, changes in sleeping patterns, changes in energy level, difficulty paying attention, feeling worthless or useless or guilty, and having self-injury and self-destructive behaviors. Suicidal thoughts and or attempts are among those possible. ADHD is displayed when 6 or more symptoms of inattention and hyperactivity impulsivity for children up to 16 years of age, or 5 or more symptoms of inattention and hyperactivity impulsivity in adolescents aged 17 years and older. Oppositional defiance is displayed when a child often loses their temper, often arguing with adults and refusing to comply with adult rules and requests, resentful and spiteful, deliberately annoying others, or becoming annoyed with others and blaming others for their mistakes and misbehavior. Treatment plans. Identify the mental health issue, whether it's depression, anxiety, PTSD, OCD are encompassed in anxiety, ADHD, ODD, and once this is established by screening, we can develop a better treatment plan. Once it is determined that the child meets the DSM-5 criteria for a specific mental health condition, then the best approach to symptom management can be determined with the parent or guardian of the child. Pharmacological versus behavioral therapy. Depending on the severity, inpatient treatment may be indicated. Pharmacological interventions include SSRIs, SNRIs, mood stabilizers, and antipsychotics, specifically risperidol. Stimulant versus non-stimulant options for ADHD treatment. Adjunctive anxiolytics such as hydroxyzine or buspirone. Provide education to the family about the mental health condition and provide supports as needed to the family. Labs only indicated if there is a concern that altered mental status may be accounted for by a medical condition. In this case, CBC with differential electrolytes and thyroid function. Refer to neuropsychology for possible autism spectrum disorder, adolescent medicine for possible hormonal changes causing mood changes, other potential referrals as needed. If concerns for physical, emotional, or sexual abuse are of concern, law enforcement may need to get involved for the safety of the child. LGBTQ population. This population includes patients who identify as lesbian, bisexual, transgender, queer, or questioning plus. This population has a diverse range of expressions of gender and sexual orientation. Many patients within this population struggle with mental health issues related to struggles to be accepted by their cisgender peers or cohort. The LGBT adults are twice as likely as heterosexual adults to experience a mental health condition. Transgender individuals are 4 times as likely than cisgender individuals to experience a mental health condition. LGBTQ plus youth in the United States is estimated at $650.16 million with associated harm such as substance abuse and suicidal attempts, totaling an estimated total economic burden of $9.23 billion. Diagnosis and criteria for DSM-5. Identifying risk factors for mental health issues include the coming out period with gender identity and sexual orientation, the feeling of rejection or feeling traumatized or discriminated against, or feeling identity shamed, resorting to substance use disorder. Some people within the some patients within the LGBT community experience homelessness as a result of being ostracized, suicidal thoughts, and attempts. Also, receiving inadequate mental health care can also impact this community heavily. And since this is a major issue, LGBTQ adults are twice as likely as heterosexual adults to experience mental health conditions, and transgender once again 4 times as likely than cisgender individuals to experience mental health conditions. Treatment plan for the LGBTQ community. Pharmacological interventions can include SSRIs, SNRIs, mood stabilizers, and anxiolytics. Another consideration would be hormone replacement therapy for transgender men and women with specialized training. Labs include CBC, thyroid panel, electrolytes, liver and kidney functioning tests to rule out other medical conditions. The LGBTQ patients need clinicians who are trained in working with this population. Some therapists have approved certification and are competent when working with LGBTQ patients and mental health issues affecting their community. Gender identity and sexual orientation affirming language is imperative when working with patients in the LGBTQ community. The clinician should be aware of his or her own beliefs and competence when providing mental health treatment. Referrals are as needed when treatment is beyond the scope of the clinician. Educate the patient, answering questions for the patient or family members about the plan of care. Provide adequate follow-up as needed for the patient. Immigrant and migrant workers population. Patients from this population migrate to the United States for better opportunities. For mental health distress comes from the U.S. culture shock. Their struggle to adjust to a culture that is not always accommodating and understanding of unique cultural practices within immigrant and migrant workers. Mental health issues are approached differently in immigrant and migrant worker cultures. Sometimes it is stigmatized, and in other cultures, alternative practices such as prayer and meditation help address mental health. Immigrants are often reluctant to seek treatment for mental health due to language barriers and fear of being found out if the immigrant is potentially non-documented or due to high cost treatment. Providing insurance for immigrants costs the healthcare system approximately $3,800 per person per year. Diagnostic and DSM-5 criteria. Patients within this population suffer from mental illnesses related to adjusting to U.S. culture, being away from their families in their native countries, being traumatized by U.S. citizens who discriminate against them. Depression, anxiety, PTSD possibly are common mental health issues. Mental health screening such as the PHQ-9 and the GAD-7 are useful tools to guide clinicians in assessing the needs of the patient. Immigrant and migrant worker patients need clinicians who've had training and working with this population. The clinician needs to be culturally competent and provide language interpreter services. Medical interpreters are preferable because sometimes family members are not as familiar with medical terminology, and this can create a barrier to adequate assessment of needs. Treatment plan for this population. Pharmacological interventions include SSRIs, SNRIs, mood stabilizers, and anxiolytics. Labs include CBCs, thyroid panel, electrolytes, liver and kidney functions tests. Immigrant and migrant worker patients need clinicians who have been trained in working with this population. Educate the patient and answer questions to the family about the plan of care, provide adequate follow-up as needed, and send over referrals as needed if the treatment is beyond the scope of the clinician. Population, ethnic and minority groups. Patients from this population include Black people, indigenous people, people of color, and females. It is imperative that training and cultural competence it is imperative to have training and cultural competence when clinicians are providing mental health treatment for patients within this population. This helps patients to feel comfortable and develop rapport with the clinician. Patients within these populations are higher risk for alcohol and substance use disorders, anxiety, depression, eating disorders, PTSD, and bipolar disorders or psychoses. In 2022, the economic cost of the mental health disparities for racial and ethnicity minorities in the United States between 2016 and 2020 was $278 billion due to mature deaths related to mental health, substance use, and suicide in the groups. Diagnostic criteria in DSM-5. Patients from these populations are at high risk for the following conditions: alcohol, substance use disorders, anxiety, depression, eating disorders, PTSD, bipolar disorder, and psychoses. Mental health screenings such as the PHQ-9 and the GAD-7 are useful tools to guide the clinician in assessing the needs of the patient. DSM-5 criteria to assess for bipolar disorder, disordered eating, and substance use dependency and schizophrenia are also helpful. Treatment plan. Pharmacological interventions include SSRIs, SNRIs, mood stabilizers, and anxiolytics. It is also important to note that among different cultures and different ethnic groups, medications are metabolized differently. Some patients require less of a specific medication for mental health treatment, and some may require more due to metabolic issues. Labs include CBCs, thyroid panel, electrolytes, liver and kidney functioning tests. These patients need clinicians who are trained in working with this population. Cultural competence is key, and clinicians should be aware of their own biases when working with this population when developing a treatment plan. Provide education to the patient as well as their families about the plan of care and provide adequate follow-up as needed. Referrals are only indicated when the treatment plan is beyond the scope of the clinician. And here are my references. And thank you for your time and taking the opportunity to view my presentation.